The thyroid hormones, triiodothyronine and its prohormone, thyroxine, are tyrosine-based hormones produced by the thyroid gland that are primarily responsible for regulation of metabolism. T3 and T4 are partially composed of iodine. A deficiency of iodine leads to decreased production of T3 and T4, enlarges the thyroid tissue and will cause the disease known as simple goitre. The major form of thyroid hormone in the blood is thyroxine, which has a longer half-life than T3. In humans, the ratio of T4 to T3 released into the blood is between 14:1 and 20:1. T4 is converted to the active T3 within cells by deiodinases. These are further processed by decarboxylation and deiodination to produce iodothyronine and thyronamine. All three isoforms of the deiodinases are selenium-containing enzymes, thus dietary selenium is essential for T3 production. Function: the thyroid hormones act on nearly every cell in the body. They act to increase the basal metabolic rate, affect protein synthesis, help regulate long bone growth and neural maturation, and increase the body's sensitivity to catecholamines by permissiveness. The thyroid hormones are essential to proper development and differentiation of all cells of the human body. These hormones also regulate protein, fat, and carbohydrate metabolism, affecting how human cells use energetic compounds. They also stimulate vitamin metabolism. Numerous physiological and pathological stimuli influence thyroid hormone synthesis. Thyroid hormone leads to heat generation in humans. However, the thyronamines function via some unknown mechanism to inhibit neuronal activity. This plays an important role in the hibernation cycles of mammals and the molting behavior of birds. One effect of administering the thyronamines is a severe drop in body temperature. Circulation and transport. Plasma transport. Most of the thyroid hormone circulating in the blood is bound to transport proteins. Only a very small fraction of the circulating hormone is free and biologically active. Hence, measuring concentrations of free thyroid hormones is of great diagnostic value. When thyroid hormone is bound, it is not active, so the amount of free T3, T4 is what is important. For this reason, measuring total thyroxine in the blood can be misleading. Despite being lipophilic, T3 and T4 cross the cell membrane via carrier-mediated transport, which is ATP-dependent. T1A and T0A are positively charged and do not cross the membrane. They are believed to function via the trace amine-associated receptor TAAR1, a G protein-coupled receptor located in the cell membrane. Another critical diagnostic tool is measurement of the amount of thyroid-stimulating hormone that is present. Membrane transport. Contrary to common belief, thyroid hormones cannot traverse cell membranes in a passive manner like other lipophilic substances. The iodine in O position makes the phenolic O group more acidic, resulting in a negative charged physiological pH. However, at least 10 different active, energy-dependent and genetically regulated iodothyronine transporters have been identified in humans. They guarantee that intracellular levels of thyroid hormones are higher than in blood plasma or interstitial fluids. Intracellular transport. Little is known about intracellular kinetics of thyroid hormones. However, recently it could be demonstrated that the crystalline CRYM binds 3,5,3 triiodothyronine in vivo. Mechanism of action. The thyroid hormones function via a well-studied set of nuclear receptors. They also act in the nucleus of the cell, the thyroid hormone receptors. These receptors, together with corepressor molecules, bind DNA regions called thyroid hormone response elements near genes. This receptor, corepressor, DNA complex can block gene transcription. When triiodothyronine thyroxine binds a thyroid hormone receptor. It induces a conformational change in the TR which displaces the corepressor from the receptor DNA complex, resulting in recruitment of coactivator proteins and RNA polymerase, activating transcription of the gene. Although this general functional model has considerable experimental support, there remain many open questions. Thyroxine, iodine and apoptosis. Thyroxine and iodine stimulate the spectacular apoptosis of the cells of the larval gills, tail and fins in amphibians' metamorphosis, and stimulate the evolution of the nervous system, transforming the aquatic, vegetarian tadpole into the terrestrial, carnivorous frog. In fact, amphibian frog Xenopus levis serves as an ideal model system for the study of the mechanisms of apoptosis. Effects of triiodothyronine. Effects of triiodothyronine, which is the metabolically active form, increases cardiac output, increases heart rate, increases ventilation rate, increases basal metabolic rate, potentiates the effects of catecholamines, potentiates brain development, thickens endometrium in females, increases metabolism of proteins and carbohydrates. Measurement. Thyroxine and triiodothyronine can be measured as free thyroxine and free triiodothyronine, which are indicators of thyroxine and triiodothyronine activities in the body. They can also be measured as total thyroxine and total triiodothyronine, which also depend on the thyroxine and triiodothyronine that is bound to thyroxine-binding globulin. A related parameter is the free thyroxine index, which is total thyroxine multiplied by thyroid hormone uptake, which, in turn, is a measure of the unbound thyroxine-binding globulins. Additionally, thyroid disorders can be detected prenatally using advanced imaging techniques and testing fetal hormone levels. Medical use. Both T3 and T4 are used to treat thyroid hormone deficiency. They are both absorbed well by the gut, so can be given orally. Levothyroxine is the pharmaceutical name of levothyroxine sodium, which is metabolized more slowly than T3 and hence usually only needs once daily administration. Natural desiccated thyroid hormones are derived from pig thyroid glands, and are a natural hypothyroid treatment containing 20% T3 and traces of T2, T1 and calcitonin. Also available are synthetic combinations of T3, T4 in different ratios and pure T3 medications. Levothyroxine sodium is usually the first course of treatment tried. Some patients feel they do better on desiccated thyroid hormones. However, this is based on anecdotal evidence and clinical trials have not shown any benefit over the biosynthetic forms. Thyroid tablets are reported to have different effects, which can be attributed to the difference in torsional angles surrounding the reactive site of the molecule. Thyronamines have no medical usage as yet, though their use has been proposed for controlled induction of hypothermia, which causes the brain to enter a protective cycle, useful in preventing damage during ischemic shock. Synthetic thyroxine was first successfully produced by Charles Robert Harrington and George Barger in 1926. Formulations. Today most patients are treated with levothyroxine or a similar synthetic thyroid hormone. Different polymorphs of the compound have different solubilities and potencies. Additionally, natural thyroid hormone supplements from the dried thyroids of animals are still available. Levothyroxine contains T4 only and is therefore largely ineffective for patients unable to convert T4 to T3. These patients may choose to take natural thyroid hormone as it contains a mixture of T4 and T3, or alternatively supplement with a synthetic T3 treatment. In these cases, synthetic liothyronine is preferred due to the potential differences between the natural thyroid products. Some studies show that the mixed therapy is beneficial to all patients, but the addition of liothyronine contains additional side effects and the medication should be evaluated on an individual basis. Some natural thyroid hormone brands are FDA approved, but some are not. Thyroid hormones are generally well tolerated. Thyroid hormones are usually not dangerous for pregnant women and nursing mothers, but should be given under a doctor's supervision. In fact, if a woman who is hypothyroid is left untreated, her baby is at a higher risk for birth defects. When pregnant, a woman with a low-functioning thyroid will also need to increase her dosage of thyroid hormone. One exception is that thyroid hormones may aggravate heart conditions, especially in older patients. Therefore, doctors may start these patients on a lower dose and amp work up to avoid risk of heart attack. Related diseases. Both excess and deficiency of thyroxine can cause disorders. Hyperthyroidism is a clinical syndrome caused by an excess of circulating free thyroxine, free triiodothyronine, or both. It is a common disorder that affects approximately 2% of women and 0.2% of men. Thyrotoxicosis is often used interchangeably with hyperthyroidism, but there are subtle differences. Although thyrotoxicosis also refers to an increase in circulating thyroid hormones, it can be caused by the intake of thyroxine tablets or by an overactive thyroid, whereas hyperthyroidism refers solely to an overactive thyroid. Hypothyroidism is the case where there is a deficiency of thyroxine, triiodothyronine, or both. Clinical depression can sometimes be caused by hypothyroidism. Some research has shown that T3 is found in the junctions of synapses and regulates the amounts and activity of serotonin, norepinephrine, and gamma-aminobutyric acid in the brain. Hair loss can sometimes be attributed to a malfunction of T3 and T4. Your normal hair growth cycle may be affected and disrupt hair growth. Preterm births can suffer neurodevelopmental disorders due to lack of maternal thyroid hormones, at a time when their own thyroid is unable to meet the postnatal needs. Also in normal pregnancies, adequate levels of maternal thyroid hormone are vital in order to ensure thyroid hormone availability for the fetus and its developing brain. Congenital hypothyroidism occurs in every 1 in 1,600 to 3,400 newborns, with most being born asymptomatic and developing related symptoms weeks after birth. Antithyroid drugs. Iodine uptake against a concentration gradient is mediated by a sodium-iodine symporter and is linked to a sodium-potassium ATPase. Perchlorate and thiocyanate are drugs that can compete with iodine at this point. Compounds such as goitre, carbimazole, methimazole, propylthiouracil can reduce thyroid hormone production by interfering with iodine oxidation.